It's now 2 minutes past 1 on my clock. Welcome everyone to the CIRA Talk series. CIRA is the Center for Interdisciplinary Research on AIDS, an HIV/AIDS research center at Yale University, supported by the U.S. National Institute of Mental Health. My name is Dini Arsono. I'm one of the co-hosts at today's event. I'm a coordinator of CIRA's HIV/AIDS International Research Program. Today's seminar is being recorded for future viewing, so presentation slides and recording will be available at CIRA website in the next 2 weeks or so. Today's attendees will also be notified by email once these resources are available. On your screen right now is a screenshot of CIRA website, cira.yale.edu, where you can find information related to CIRA-affiliated individuals, research projects, past presentations, and other resources. Everyone is welcome to visit the website and sign up for the CIRA e-bulletin, which is our center's monthly newsletter. A reminder for upcoming CIRA events. So the Qualitative Research Discussion Group will have their monthly meeting this Friday at noon. The event is open to all. The link to the event details will be posted to the chat shortly. To avoid audio interference at today's talk, please keep your mic off unless otherwise directed. And today's presentation will be followed by a discussion and a Q&A session. But we would like to invite you to use the chat function throughout the event to submit your questions and comments. And a very quick reminder that at the end of the event, there will be a very brief survey, and we would like to invite you to share your feedback to inform our future events and activities. So today's CIRA Talk, Sankofa 1 and 2, Implementation Research to Optimize Disclosure of HIV Status to Children in Ghana, will be moderated by Dr. Luke Davis. Dr. Davis is an epidemiologist and pulmonary critical care physician whose research employs implementation science to improve the diagnosis, treatment, and prevention of tuberculosis, TB, which is the leading cause of infectious death in low and middle income countries. Dr. Davis serves as a scientific advisor for CIRA's International HIV/AIDS Research Program and a co-chair of the Yale Global HIV/AIDS Research Network, or GARNER. Dr. Davis is associate faculty member of the Center for Implementation and Prevention Science at the Yale School of Public Health. And with that, I will turn it over to Dr. Davis. Thank you.
Thank you, Dini. I just want to welcome everyone to today's CIRA Talk entitled Sankofa 1 and 2, Implementation Research to Optimize Disclosure of HIV Status to Children in Ghana. And I'm really pleased to have the opportunity to introduce two friends and outstanding speakers and a wonderful discussant today. I'll begin by introducing Dr. Elijah Paintsil, who's professor of pediatrics, pharmacology, and epidemiology, as well as management at Yale University, and also the chief of pediatric infectious diseases and global health. Elijah is a laboratory-based and clinical investigator with a major interest in understanding how ART affects mitochondrial function and pediatric HIV treatment outcomes in research settings, including Ghana. He's also PI of an R01 to study the benefits of pediatric HIV disclosure in Ghana. The second presenter that I'd like to introduce today is Professor Nancy Reynolds, who is Associate Dean of Global Affairs at the Johns Hopkins School of Nursing. She's also the Director for the Center for Global Initiatives and Director of the WHO Collaborating Center for Nursing Information, Knowledge, and Management, as well as Vice Chairman of the Consortium of Universities for Global Health. She's an NIH-funded researcher whose research is focused on the development and testing of interventions that bring healthcare services to vulnerable populations affected by HIV. As many of the attendees know, we also, in addition to having these wonderful presenters, like to include an expert discussant. And today, I'm fortunate to introduce Dr. George Seabury, MD, MPH, who is Medical Officer and Senior Technical Advisor for HIV treatment in the Office of HIV/AIDS, the Bureau of Global Health of the U.S. Agency for International Development. Dr. Seabury joined Yale as a part-time faculty member in the Department of Pediatrics in 2019. Prior to coming to Yale, he was a medical officer at the Maternal and Pediatric Infectious Diseases branch of NICHD at the National Institutes of Health in Bethesda, Maryland. And he also served as a senior technical advisor at the Office of the Global AIDS Coordinator, which oversees PEPFAR, and then is now in his current position as medical officer in the Office of HIV/AIDS at USAID. So welcome very much today to Elijah and to Nancy and to our discussant, George Seabury.
Well, thank you so much for the introduction, and I'll just get my slides up here. Great, can you see those all right?
Yes, looks great,
Great.
Nancy.
Okay, thank you so much. And it's really a pleasure for us to be with you today and get a chance to share about this work that we really have been involved in for quite a few years now. We just thought we'd start with giving a little bit of an overview of the problem area we're addressing and a little bit about the background that's relevant, and then talk about the first study that we've completed, Sankofa-1, and then talk about where we are in the follow-up study, Sankofa-2. So sub-Saharan Africa continues to have a very high burden of pediatric HIV. And with improved access to antiretroviral therapy, children infected with HIV are living longer and now into adulthood, which they weren't several years ago. And the WHO recommends that children as young as school age, 6 to 12, be told of their HIV status in a developmentally appropriate and culturally sensitive manner. And this is really because the available data when they made these recommendations really showed that timely and supportive disclosure can confer many benefits to the children, but a lot better psychological adjustment, better adherence, better clinical outcomes, and lower risk of transmitting HIV, obviously, when the child becomes sexually active. But our work, especially when we started, showed that as many as 75% of children in some regions have not been informed that they have HIV. And this is for some pretty obvious reasons, that it can be very complex when children are involved, and because a lot of different sociocultural barriers that make their caregivers reluctant to tell them. And when we began this work, there really was very limited research examining this problem or interventions available to try to overcome the problem. So thanks to the early work of Elijah and one of his medical fellows, she really was the first to really start to look at disclosure rates in Ghana. And she found that at the time, there was a rate of only 21% disclosure rates. Only about 20% of the children were being told they had HIV. And then we did a follow-up study, a qualitative study, where we interviewed both caregivers and providers to identify sort of what some of the key barriers were. When we talked to the caregivers, their main concerns were they thought they were really going to it would upset the child, that it would burden the child knowing that they had an illness. Many were afraid that the child wouldn't be able to cope. They were also worried that because of the high rates of stigma around HIV in this country, that the child would tell others, and the whole family would be open to stigmatization. And some of them were concerned that the child would be angry at them. And they also felt like they had a lack of disclosure skills. So they basically said to us, this is a provider matter. They've got the skills. They should be telling the child. But when we talked to the providers, they raised issues such as lack of time, really not part of the clinic culture. And they really felt uncomfortable with their skill set, too, to tell children. And they essentially said, this is a family matter. So consequently, no one's telling the child. So we decided to develop an intervention to see if we might be able to encourage more caregivers to disclose to their child. And as I said earlier, there wasn't any interventions available at the time that had an evidence base. So we base this really on a series of HIV health behavior work that I've done around adherence over a number of years, as well as some of that early descriptive level work that we did. And we decided to select train one clinical clinician in a given clinic to really develop a skill set to be able to raise this issue with caregivers. We guided the intervention by the information, motivation, behavioral skills model of health behavior change, which in obvious ways says that, we anticipated that the caregivers would need information, why this was potentially advantageous thing to do. They would need the motivation to do it, as well as they would need a skill set to disclose. The intervention is manualized, and we expect the content to be very contextualized to the caregiver and child's sociocultural environment and the developmental age of the child. So obviously younger children would get a little bit simpler information and presented in a different way than an older child, the type of information they might get. We also individualized the process, that it would be delivered over time, and we had different sort of content that would be delivered pre-disclosure, at the time of disclosure, and then post-disclosure follow-up with the caregiver if they, had decided if they had successfully disclosed to the child. And we did not do this like 6 sessions and now you have to tell the child. We use motivational interviewing type skills where the clinician would bring the issue up with the caregivers, discuss it with them, not put pressure on them, but provide them and help them develop the skill set to tell the child if they decided to do so. And we decided we had a grant planning meeting in Ghana. And I need to turn this over to my colleague, Elijah, who can say how we came up with why we called this Sankofa.
Thank you very much, Nancy. And before I continue, I think this has been weighing heavily on me for some years now, and I just want to make a confession, because George Sibrey is here today and he's the discussant. So as Nancy showed you, a medical student, Stacy Kalim, started all this, going to Ghana to find out that the disclosure rate was poor. And we published that. I wasn't interested in disclosure at the time. And George Sibrey then at NIACHD emailed me about the possibility of they putting out an announcement for people to apply to study disclosure. I've tried very much in my life not to lie, but on that day, I was succumbed to lying. So I lied to him that, yes, we will be interested in doing this. And so when I realized that I've lied to George, I had to gather myself and ask people. And that's why I talked to Nancy and others that I've lied and I want to correct it. If you can help me put up this study. So please do not do that. The only time I have lied that I've been rewarded is this one time. And I've learned my lesson. So I'm not doing it anymore. But so we decided that we have to go to Ghana, and we had this planning meeting. 2 hospitals, Kolebu Teaching Hospital and Komfo Hospital, that will go on. And then we were thinking about how even to call this study. And around the table, when we were discussing, it came out that maybe this is something that we shouldn't even study. This is something that should have been done naturally, but we have not. We have forgotten to do. So this mythical bird in Ghana came handy, Sankofa. And as you see, it's a 3-syllable word, Sankofa. Return, go, and take. And it's the southern part of Ghana. They are Akans, and they believe that you really have to go back, retrieve knowledge to be able to go forward. So we decided this is great. Let's call it Sankofa. We are going to go into why these kids are not being told their diagnosis, and then also based on the evidence, go forward. Next. So that is the Sankofa. So we're trying to test whether a clinically based pediatric HIV disclosure that is culturally acceptable, very sensitive, and delivered by the people in the clinic, in that setting would have disclosure that was poor. So the aim was to evaluate the effect of a structured, culturally relevant disclosure intervention. It was going to be delivered by a specialist, what we call the disclosure and adherence specialist, who is part of the hospital or clinic, and she or he knows about the cultural undertones and the people very well, and could also be done in a follow-up way. It's not just one-time shot. So we then, no-brainers, hypothesized that a structured intervention will lead to increase in 1 year. And then so we did site randomization because we were just testing this out. So only 2 sites, the intervention site, that is the, as you see in the flow chart, KATH, meaning Comfort Anochi Teaching Hospital, and KBTH, Kolebu. So henceforth, I would just say Comfort Anochi and Kolebu. And so we targeted 7 to 18. As Nancy already said, the WHO usually wants kids to be disclosed to during school age time. From 6 to 12 years is ideal. And an American Academy of Pediatrics also subscribes to that. And so these people would be met in the intervention side. They would meet every clinic time, 3 months, every 3 months, they would meet with the interventionist and go through that. The same happened at the control site, care as usual, but because of the intervention site having a specialist, we also had a specialist there who just talked about general health issues with them, so that we canceled out that dose effect. We also didn't do this in randomized in the same facility because of fear of contamination. So that's why we chose to start off 2 independent facilities with similar structures. Next. And these were some of the measures that we took every 3 months when these kids came. So we have questionnaires for the caregiver of the child, and we have questionnaires also for the child. And then the doctors, pharmacists, and then the counselor, the person developing that. And as you can see, we went from just social provision, HIV knowledge, how they consider their condition as stigmatizing, with a depression. And these are all questionnaires that have been validated in the sub-regions that we use. Next. And at the time, one of the things that we did that we were so proud of is the data, web-based data design and organization. We collaborated with folks at Purdue University that were actually designing a web database for the defense, Department of Defense. So we prided ourselves that, oh, so this will be very secured, really curated database. And as you can see, we have the clinics, one at Kumasi and one at Accra. They were feeding the data into this web base. So it was online data storage. The people who took that would input on the web base, and then it would be available for viewing, searching, reporting, comparing, and searching. The important thing, though, was that not every member of the team had access to all the data. For instance, Nancy and myself being the PIs, actually, we couldn't get the disclosure data. All we could assess was how many people have been enrolled. but the primary outcome and secondary outcomes, we could not. But we have statisticians at Yale Center for Analytical Science that could help do this. So you can see University of Ghana and then the Confidential Hospital. And at the time, Nancy was at Yale School of Nursing. So that's why you see that. Later on, when we go on, it will be Hopkins, and I still remain here. And so this helped us to interrogate, search, and we actually had a functionality where the person who is inputting the data, if there is a mistake or some missing, the person is alerted that there is a missing data. So we thought this was really very cool. It turned out to be expensive, so we didn't use it later, but for a start, it was good. Next. So these are some of the results for the Sankofa one. So the demographics of the children. And again, we have the treatment side that is appearing on the second column and the control side, Kolebu. The control meaning that we let them do whatever they do in their clinic, except for the fact that at each visit, we had somebody also counseling them on general health and not really talking about HIV disclosure. So by and large, I think we really match these people very well, except for age, where the control side at Kolebu tended to be a bit younger at a mean age of 9.3 compared to 10.17. And then these are the demographics of the caregivers. Also did a very good job between them. Interesting thing is education. The folks at the control side tended to have more the secondary education, about 45% of them. So that skewed that. And then also folks at the control side tended to have a higher income, about 38% of them having more than 300 Ghana cedis. As of today, $1 equals to 10 Ghana cedis. So you can imagine these are really very low income overall. Next. And so the primary outcome, that is disclosure at 1 year, has been published in Journal of AIDS. And I'm going to take you through this. But the main point to share with you is that children in the intervention side or the treatment group had significantly greater disclosure at each time point. So we were seeing them every 3 months. They had that. And at 1 year, they were about 4 times more likely than the control group to have been disclosed to. Next. So this is the curves, Kaplan-Meier curves showing you the probability. And if you look at the unadjusted on the left panel, so probability of disclosure, and then x-axis being time, so 0 to 12 months. And then I want you to pay attention to the red line, which is the control. The blue is the intervention. You can see that this widened. Right from 3 months, we began to see effect of the intervention. And on your right, when even it was adjusted for caregiver age and then the age of the child, as we saw in our demographic, and caregiver status, you still have very significant increase over time with the blue line, meaning the intervention side. So definitely whatever we were doing, the intervention was working and empowering the caregivers to disclose. Next. Again, this is at 3 years. If you continue, it's about the same. I mean, we still had the effect of the intervention increasing that. And if you even look at the red line, that is the control, I mean, they limped around 20%, as Stacy saw in the first study. So 3 years. And again, what this probably may mean is that a lot of these caregivers were believing that the kids have to be older before you disclose to. So that's why probably with time, we were getting sort of increase, but nothing compared to the intervention side. Next. And these were just some of the things that predicted disclosure at 12 months. And again, as you might have already heard, intervention predicted disclosure, the first arrow sign that you see. So kids in the intervention were more likely, like we said, about 4 times more likely. An interesting thing that also we found was if you stratify the kids into less than 11 and greater than 11 or older, you also see this disparity that were coming in. So age at time of disclosure was very important. And caregiver HIV status tended to be a positive predictor. And then, of course, education, having a secondary education, and also having high income predicted disclosure. Next. So then we looked at the intervention side, Confirmatory Teaching Hospital, and asked the question, okay, this was the intervention side. Not all the kids. We enrolled about 240 of them, but not all of them were disclosed to. So were there any differences between kids who were disclosed to at the intervention side and those who were not? And mainly what came in play was child age. Those who were not disclosed to tended, you see that they not disclosed, where they probably their caregivers wanted to wait so the kids were over 11 years old. So that came into play. And then again, caregiver HIV status was distinguished that. So once the caregiver is HIV positive, it was more likely that he or she was going to disclose. Next. So factors that were associated with disclosure at intervention side, again, age became the most important. And then we actually found out that at the intervention side, the intervention was actually helpful in helping the caregivers disclose at less than 11 years, which a lot of people said, oh, just wait till they are adolescent, 12 years and above. So we definitely found out that if you empower the caregivers, they would be disclosing regardless of the age. And also with age, which had been something that has been the conventional wisdom, that kids will be disclosed to as and when they grow. That's exactly what we found. Next. So this is just showing you probability of disclosure at 12 months, more like looking at less than 11 and greater than 11. We did this because people at the time thought that, oh, especially caregivers, the kids should be 12 and above. That is, they would understand what is an infection and what have you. If you look at our study, look at panel A, you look at it again, blue meaning the intervention. It really didn't matter. Less than 11, they just weren't aware disclosing. So age was not a problem. If you look at the control, they were obeying the conventional wisdom. Nobody was even disclosed to at less than 11, as it seems. The curve was flat. So with the right intervention, we could put this to death, that it's a myth. Once you empower the caregivers, they would be able to provide. Again, the same thing as you see in the control side tended to disclose more when the kids were older. But again, it wasn't up to the rate at which the intervention side was being that. Next. We have since done a lot of analysis, and we're just showing you one. Because at the time, caregivers always said that if you disclose, the kid would be distraught and it could bring depression and some mental health issues. As you are seeing in this, when we looked at the kids after 48 weeks, we didn't really see any difference. There was really no tendency for depression. We did this 48, 96, one for the 4 weeks, and then we actually had data going as far to 3 years, and we didn't see any depressive symptoms or scores going high in the kids that were disclosed to. So definitely, the HIV disclosure intervention did not worsen depression scores in the children that we administered this to. Next. So I would now, Nancy will take over and give you take-away points from the first Sankofa.
Yeah, so we concluded from this first trial that a structured, culturally relevant, and personalized disclosure interview significantly improved pediatric HIV disclosure rate in Ghana. Age of child was predictive of disclosure at 1 year. Children less than 11 years were more likely to see a difference there, that the ones who did not receive the intervention, as Elijah was just saying, were essentially not disclosed to at all during this study. This was the first pediatric HIV disclosure intervention trial in sub-Saharan Africa to provide this sort of empiric evidence in support of WHO's recommendation to disclose to children at a younger age would not be damaging to them. But we concluded at the end that the study had a few limitations. One, as Elijah mentioned, we didn't want to randomize within a site because we thought once the clinicians are trained, you can't just like not deliver the intervention once they learn it. So we thought we really had to randomize by site, but we only had 2 sites. And we also had 2 high-functioning clinics that do a lot of research. So we really thought that the study should be replicated in a larger scale trial with diverse clinic representation. So this led us to designing and thankfully getting funded Sankofa-2, which we call Pediatric HIV Disclosure Benefits Study. And in this study, we aim to build on the successful Sankofa-1 trial by testing the intervention in many, much more just real world clinic conditions in Ghana. And we are using a pragmatic stepped wedge cluster randomized trial in 13 HIV pediatric clinics in Ghana. So our aims are to examine the effectiveness again of the intervention. We're going to assess the health benefits as we did in Sankofa-1, but also we've added a cost effectiveness component to this trial. And then we are also evaluating the implementation of the trial. So specifically, we're looking at acceptability, applicability, feasibility, fidelity, penetration, and maintenance or sustainability of the disclosure intervention in these more random conditions across several different types of clinics. So we are using seven treatment centers in Accra and 6 in Kumasi. All sites receive the intervention, but the participating sites are randomly assigned to the sequential introduction of the intervention. So this allows simultaneous evaluation of the effectiveness and the implementation of the intervention. And this will also help us to assess the natural history of disclosure. So you can see in this figure here how we had a period here in the light blue for 6 months where we were distributing questionnaires, but the intervention had not been introduced into the clinic. And then after that 6-month interval, our first set of clinics received the intervention, and then 6 months later, the second set of clinics are receiving the intervention, and so forth. And once obviously the intervention is introduced, it continues to be delivered in that site. So we are hoping to recruit 720 dyads. And I just have a few specifics about the inclusion and exclusion criteria. We had, of course, the protocol had to be reviewed by a number of different clinics. And again, this is just showing the control condition and the experimental condition and how these get rolled out. We're using essentially the same measures that we used in Sankofa-1, but this time we have added measures of implementation, as I was mentioning, and we have several different measures to do that. And we're also doing, cost analysis. All the data collected from the study assessments are being entered directly into Yale's secure web-based clinical research management system, ENCORE, and data is entered into the ENCORE system by research staff in Ghana. So the forms stay in Ghana, but we're able to see a real advantage with this is we're able to see the data in real time. Obviously, we can't we can't see certain aspects of the data as the investigators, but it's there to see missingness of data and that sort of thing. And this is the analyses. I don't believe our statistician, our wonderful statistician, is with us today, but this was I don't expect you to be able to read this, but this is just a figure that she developed that really helped to guide the fairly complex analyses with this kind of situation. And we're using Cox proportional hazards model with the frailty term for the effective clinic and the intervention for a time varying factor to estimate a hazard ratio, the 95% confidence interval. And again, our primary thing is at 48 weeks follow-up. And then because of the time dependent introduction of the intervention, we're also implementing this time on study scale, discrete survival model. And again, we're doing cost analysis, and then we're using mixed methods for the implementation data. This is just our study timeline, and we've been collecting data for 2 years as of June, and we are on course. And in fact, we've been meeting regularly with the team, Elijah more than myself, but it's been really wonderful that we've been able to conduct this study throughout COVID. And it's really because we had such a fantastic team from Sankofa-1 that were in place when we started Sankofa-2 that Elijah and I really could have regular telephone calls. We have them bi-weekly for the most part, but I was able to do trainings with the clinicians who did the intervention delivery in Sankofa-1, and they now are the trainers for the clinicians in all these different clinics in Ghana. So this is the Kumasi team and the Accra team, and we met with them in December of this year. And it was really terrific just to see all these, dedicated people to the study and able to, address any issues that might have come up. But I just have to say, anecdotally, I met with the clinicians who had learned the intervention, and it was really pretty moving. A few of them were literally in tears talking to me about how meaningful learning the skills of this intervention had been for them. And just they had felt sort of helpless. They knew it was an issue, but learning these skills, it was so effective in their ability now to engage with the caregivers and bring up the discussion. So I don't know, Elijah, if you have anything to add to this. In terms of challenges, it's been remarkably smooth, but.
Now, Nancy, you've said it all. And I think Nancy and I have been very fortunate and privileged to have this team. I mean, when we took this picture, I look at it back and I say, oh boy, we've been fortunate that over the years, we started building this team 2012. And they've stuck with us, and we have expanded. And as Nancy said, even during COVID, they were still working, and when we couldn't go there. So we're very grateful to the people on the ground.
Yeah, and I just want to end with this model that came to mind when I was pulling these slides together. This is from when I was in my PhD program. One of my professors had developed this model about on research development towards utilization and practice, where if you don't know much about the area, you're going to start with exploratory research and then descriptive research, looking at the relationship between variables, and then testing it in a controlled trial. And we know that oftentimes that's where research sort of stops there. And now with what we call implementation science here, the real thing is getting it from a clinical trial out into the field. And I just thought, oh, this model just reminds me of how we've been so fortunate to sort of have this whole range of research. And I do think, actually, if this trial shows that the intervention is successful in these varied clinic conditions, that we have a good chance that this will become standard of care in Ghana. We actually have somebody from the Ministry of Health who's on the team, and it seems to be so well received based, again, on anecdotal information, but we are trying to capture that with our implementation measures. And I'll just say many thanks to our participants. It's so thankful for them to give up their time for us to be able to collect data for this study. And of course, to NICHD, they've been a wonderful institute to work for. We're so appreciative. And then, of course, this amazing team of investigators, coordinators, data managers, study staff, and clinicians that we've been working with. So I will stop there.
Thank you so much, Nancy and Elijah, for the superb presentation. I think we all have learned a lot. I'll next invite Dr. George Seabury to give some thoughts and comments. In the meantime, those who are interested in asking questions, I remind you to enter them to the chat, and then we'll try to collect those together and ask those to Nancy and Elijah.
Thanks very much, Luke, and Nancy and Elijah. Just so fantastic to hear this terrific work. I remember in 2012, Elijah, when we put the RFA out at NICHD for disclosure of HIV to children, how excited I was that you put in a successful application, and just to see it kind of grow and produce these terrific results. You know, I think this is such a nice example of where we have a guideline, often based on more expert opinion than evidence, and how you took that and then sort of found a way to generate that evidence and then think about the path to sort of scalability and implementation. And I think the evidence you presented shows how a sort of routine structured approach does result in more timely disclosure to children, and that it's feasible in a busy clinic setting, and that a lot of people were worried that there could be negative effects on the child or on the caregiver, and that there was really reassuringly no evidence of those things. And so I just, again, gratifying and motivating, I think, for a problem that those of us who have taken care of kids with HIV sort of over their life course really appreciate, because it's something that was so dominant in our sort of daily work, and yet uncertainty about how to deal with it. So I have a couple of questions, if I can, Luke, to ask of Elijah and Nancy, and then I'm sure others will have questions too. I think one of the aspects of scalability relates in part to what the training looks like and what level of person can do this training. Can you describe first what level of person at the clinic site that you chose to take on this training? Was it a nurse? Was it a physician? Was it a counselor, maybe something like a social worker or psychologist? But could you describe that a little bit for me?
Sure. Yeah. So with the Sankofa-1, it was a nurse and a clinical psychologist at the clinic who split up the responsibilities. And I did the training with them, and they had not been exposed to motivational interviewing before. But, I think many people on this call are probably familiar with it. It's quite a complex technique, but I was able to really, hit the important points of not sort of putting pressure on them, accepting what the caregiver, where they were, providing information, and, that was appropriate for what stage of interest the caregiver had. If they weren't interested, that was fine. And they really learn those principles. Now they're doing the training, and they're using a variety, but some of them really are nurses in the clinic. Quite a few of them are nurses in the clinic that are being trained.
I mean, I think it's so helpful because in a lot of places in sub-Saharan Africa, it is predominantly the nurses that are delivering all of the care, right? Starting treatment, all of the care. And I think as you expand to look at these greater number of sites, the more that you can make that training applicable to, a routine nurse, not a sort of highly specialized nurse or a clinical psychologist, the greater the likelihood that it'll be scalable even out to smaller sites, not just these big sites. And I think that would be most welcome. I'd also add that motivational interviewing probably would have applicability beyond just HIV disclosure, right? Adherence to medication, counseling about other things that these children face as they become teens, and frankly, children who don't have HIV face as they become teens. So I think perhaps even thinking about how this gets incorporated into pre-service training for nurses might be an extension on this that could extend the benefits even beyond this important but more narrow HIV disclosure to kids.
Yeah, I really agree with you. And I really appreciate your comments about keeping it simple. And I would say our intervention is manualized. It probably seems a little complex, probably just to deliver it and, as is in a written form. So that is something I have had in my mind, and this will help to encourage me to pursue that, to try to put it in a quite easily digestible form.
Awesome. And Luke, I have two more questions, and then I do promise to give time for other people who have questions to ask. So one of the things I wonder is, I feel like you've gotten this path to success for deployment in Ghana. How different do you feel the intervention, the approach, the training, the applicability is sort of more generally, so outside of Ghana? I heard from your data, the same sorts of reservations and patterns of behavior that frankly I saw in Baltimore when I used to take care of kids there. And so it feels like the same barriers transcend countries in many ways. But I wanted to check in with you to say, could this Ghana example be enough for people to kind of start and plan a broader scale deployment in other countries where they're trying to do a better job with disclosure?
Yeah, I think that's a really great question. And honestly, I had developed a telephone delivered adherence intervention in the US, which then some colleagues in India said, I think this has a lot of applicability to women in India who tend to get isolated and drop out of care. And yet we were a little reluctant just to bring the intervention there and deliver it as is. But it's interesting you should make that point. We did, descriptive, we did, qualitative work, talk to women to see, what did we need to really change about the intervention. And honestly, it was their issues were very similar. I think how they play out in the culture is different, but same issues, stigma, depression, all these things we know about adherence. And I think that's very true for this. I bet if you talk to parents in many different countries, they're going to bring up the same issues that these parents brought up to us in our focus group. And I do, I think though, in the way we've developed it is that we expect that the clinician delivering the intervention is the one who then contextualizes it. We hope that they're the ones who have the familiarity with the sociocultural context and adapt it.
Makes great sense. And I'm glad to hear it, because I would hate to see each country feel like they needed to start from scratch, right? And then take a lot of time to get to the wider implementation level when it's needed now, right? Not 5 more years from now. All right, my final question before I let others come in is, we disclose to kids, we have lots of ideas about how we think is going to be best to look for sort of adverse outcomes or impacts. But I've often wondered if a sort of structured, systematic interview of those kids after disclosure, and maybe not right after, because they might be 8, 9, or 10 when they disclose, but when they're 15 or 20, ask them, do you remember it? Well, how did you think it went? Oh, you know, do you think there'd be a way, as we continue to help kids now, that you would suggest could be better? And I'll tell you as an example, anecdotally, when we would talk to kids, they'd say, well, I knew I had HIV already, but I knew my mom didn't want me to know. So I pretended I didn't know. And she was really upset when they told me. So I acted upset because I thought that's what I was supposed to do, right? So it's beautiful in some ways, right? Just the insight and the care, right, of this child in relation to the caregiver. But it can confuse, I think, our interpretations maybe in that moment. And so I just wondered if you've tried to look several years later to interview kids who had this disclosure intervention, just to kind of do that after action review when they were older and maybe had more time to think about it.
So George, I would take that question. This is an excellent one. And I also want to use this opportunity to ask for your formal forgiveness for lying to you.
You are forgiven, Elijah.
Thank you, thank you. So I think this is like you did to me prior. This could be the next grant. We would definitely have to look at this. I mean, I think the endurance of it. We may see a little bit in the current one, but it will be, and we know these kids. I mean, they are known in the community. So I think it will be a missed opportunity. But so thank you. We would definitely do that, Nancy.
Yeah, and I absolutely, and we don't really have insight into that issue. So we really should systematically collect data, because I suspect the same thing that you do, that a lot of these kids do know they have HIV and they've gotten the message not to talk about it. And I honestly think that's why some of our mental health outcomes improved, because it brought about the openness that the kids could finally discuss it with their parents.
Fantastic. Thank you so much. And Luke, I could come up with more questions, but I'd like to turn it back to you to make sure we get questions from others who are attending today.
Oh, thanks, George. Fantastic discussion and perspective shared there. And it's really neat to kind of hear about the long line here between you and Elijah and Nancy in conceiving of this work and making sure that it gets carried out. I'd like to recognize Gloria Idu Frimpong, who has a question. Please unmute yourself, Gloria.
Okay, thank you so much. This was really interesting work, listening to everything that has been done in this area, especially when you think of its children and its disclosure and how that works out. I think the first two questions I had was asked by George, but then I also had another question concerning Sankofa, especially because, you know, the concept of, you know, you taking something, looking in the past to to do something for your future. So I would have loved to just know a little bit about what, in terms of the training or the curriculum, like what did it entail? Were it using, traditional ACAN, concepts, especially for Sankofa? And please, let's try and mention it. It is Sankofa. I was like, wait, when you first mentioned it, I was like, wait, what? And then I read it. So I was like, oh, Sankofa, as in go back and take. So yeah, because the word Sankofa is not tree at all. It's not Akan at all. And so trying to understand that. So are there, elements, of the culture that was incorporated into this training to help? Because it was very successful, right? In all the outcomes. And so I wanted to know if there was anything like, unique from the context that was applied in here.
Thank you very much, Gloria. I think it's you're showing your Ghanaian heritage, and we can't beat that. So we will not be 100% in answering your question, but we took that into account, and that's how the name came. And that it's more of investigation, going back and seeing what did we do right and what did we do wrong. And as Nancy said, we just took people from the clinic who actually, and it were actually interesting. The clinics, the first two clinics, they elected who should be. And by default, we actually didn't say that it should be a doctor or nurse or that. And it ended up not being a doctor. And one of them was actually the first two were not nurses at all. One was counselor and one had psychology. So they help us to make it more local, culturally sensitive. And that, I think that is the aspect that we bring to this, that they determine, they work with Nancy and myself, what is acceptable to these moms? What can we even discuss in these interviews? So that is what the Sankofa part of it.
Yeah, and we wanted to use a term that was sort of familiar to people in this setting too, that they would feel comfortable in. We weren't sure about how all the participants would feel about going into a research study, and this seemed like an approachable term, as I recall.
I wanted to ask
Thank
a
you
question.
so much.
Oh yeah, go ahead, Gloria. Did you have any other questions?
My second one was I wanted to find out, especially with the sites, right? Starting with Accra, like Confanochi is huge, and what do we call Kolebu is also huge, right? And these people see large number of patients each time. So was there anything beyond that that informed, like, you know, that we are going to go into Accra, we are going to go into Confanochi, or it was, you know, just because first of all, you know, they had access to the patient population, and then also in terms of, you know, being a teaching hospital, both of them have some experience with research.
Yeah, you all of the above, Gloria. We already, before Sankofa, we were working with them, so we had collaborations with them in different aspects of HIV, and then also they have the resources. And then we also, one thing that you said, they actually see the most HIV patients, and they are the busiest clinic. I mean, so they, in Accra, they have 4 clinic days in the week, and they see over 100 kids. So we wanted a situation where it's busy and see if we can do that. So for Sankofa 2, now we are in the clinics where there are fewer. There is actually time to do this. We are at Otafo, we are at Wejabawe, you would understand those terms. And so it helped us to now go to some of these clinics. So you're very right. We thought the same way.
Well, I just want to close the session now as we're coming to the end of the hour, and give a special thanks to Nancy and to Elijah for this extraordinary work, to George for his insightful comments, and to Gloria and to everyone else in attendance. These sessions will be continuing in the fall term, and we just invite you as you sign off of Zoom to take a few minutes to answer the 2 or 3 questions that'll pop up on your screen. Give us your feedback on this session. What would you like to see in the future? And in the meantime, stay well and keep up the good work. Take care now.
Thank you.
Yeah.
Thank
Bye-bye.
you.